Hi, I'm Dr. Michael Swor. I'm a GYN surgeon in Sarasota, Florida. And our presentation is Microlaparoscopic Method for Selective Appendectomy and Gynecologic Endometriosis and Pelvic Pain Surgery. This is my financial disclosure, research support from Boulder Surgical. So as an introduction, through years of experience, we've found that the appendix is commonly involved in pelvic pathology, especially endometriosis and pelvic inflammatory conditions. We've found it to be a source of pain in many patients with acute and chronic disorders. And we've also found that laparoscopic appendectomy without acute appendicitis is a fairly simple, safe, and quick ancillary procedure with a low complication rate. With smaller microlaparoscopic instrumentation, there's a need for smaller gauge, higher quality, advanced instrumentation to address appendiceal disease. The trends in laparoscopic surgery we've seen went from laparotomy before 1980 to the advent of laparoscopy and its expansion in the 80s and 90s and into the 2000s and 2010s with the addition of robotics. That was all with larger instrumentation and larger port sizes and trocars. And now we have further advances in smaller instrumentation, better instrumentation, and in our case, using 3 to 5 millimeter instrumentation for the most part. So there's available now high quality 3 to 5 millimeter laparoscopic instruments, including a new laparoscopic stapler device, 5 millimeter size, that we use primarily for appendectomy. So our study, we had patients that were scheduled for laparoscopic treatment of endometriosis or other conservative procedures, or laparoscopic hysterectomy. And the surgery was planned, and during the surgery, the appendix, as part of the normal procedure, was visualized. And if there were any abnormalities or the patient had chronic pain, especially right lower quadrant pain, then we typically did appendectomy as an adjunct procedure. The setup was typical for laparoscopy, except that we used the smaller incisions whenever possible, 3 millimeter. The low impact, constant flow, low pressure CO2 insufflation. And we did follow the ERAS, Enhanced Recovery After Surgery protocols, which we've been using for 3 years. Mainly the minimal opioid use. The procedure itself for appendectomy, we isolate and mobilize the appendix, treat the mesoappendix with bipolar and sharp dissection or combination radiosurgical harmonic energy. We get to the base and then employ the 5 millimeter stapler. Transect and seal with the staples, observe the staple line, and extract the appendiceal tissue, either with a tissue extraction bag device or without. This is a quick video showing the procedure. We isolate, mobilize the appendix, treat the mesoappendix. In this case, we're using the combination radiosurgical harmonic energy device for the dissection. Working down to the appendiceal vessels at the base of the appendix. And in this case, we're using a 5 millimeter primary port and 3 millimeter accessory ports in the right and left lower quadrant. And then the stapler across the appendiceal base. And transecting, and then removing the tissue extraction, in this case without a tissue extraction bag. So our presentation we submitted, we had 23 patients with a mean age of 41 and a mean BMI of 26. The primary surgical findings were typical, mostly endometriosis. For the appendix, we noted either any one of these findings: fibrous thickening, nodularity, inflammation or adhesions, simple distension or edema, a palpable fecalith, or in many cases visible endometriosis lesions or other lesions, or torsion. These are examples, some endometriosis lesions and minor inflammation, denser nodularity and endometriosis. We found 2 neuroendocrine tumors, surprisingly, more fibrosis, torsion, dense adhesions, endometriosis. So all of our patients had a normal postoperative course and no significant complications, with 4-day average use of the rescue meds tramadol and 6 days using NSAIDs, and we felt a quick recovery and good patient satisfaction on a 5-point scale. So the bottom line is scheduled laparoscopic surgical cases. The appendix was commonly involved and is commonly a source of pain, and any visible pathology warranted appendectomy. We used the 5mm stapler versus other methods that we've used in the past, notably 12mm trocars and staplers. There are limitations. There's surgeon training and using the devices, understanding appendiceal disease, and various methods for safe tissue extraction. So in conclusion, smaller instrumentation and refined surgical techniques have expanded our capabilities, and we can safely and effectively use 3 to 5mm instrumentation and ports to do our surgeries, including selective appendectomies in certain cases, with a high success rate and low complication rate, high patient satisfaction. We did do 34 additional cases to add to our presentation today, and we divided those into hysterectomy and conservative laparoscopy, and had similar findings with pathologies, and the pain usage separated out into 2 minor and major cases. Thank you.